So, good afternoon, good morning, good evening, wherever you are. We are going ahead with the third session, and this session is onto neglected foot and ankle trauma. If we talk of countries which are yet developing, the neglected cases are in a huge amount, and that's where we have kept these two sessions of neglected trauma. This is the first session onto neglected trauma. The session is sponsored by CONMED. We are extremely thankful to CONMED for sponsoring this session. Let me start by sharing my screen, and I want to introduce our esteemed faculties who are there for today's. Are you seeing my slide?
No, sir.
Yes. Seeing my screen?
No, no, not yet, sir.
Uh, I'm sorry. Let me try again. I'm trying that. Okay, it tells me to do it again. And let me try and do it again. It's not allowing me to share the screen. Anyway, so for not wasting much of the time, I would ask individual speaker, Dr. Siddharth Sharma, Dr. Girish, Dr. Rahul, and Dr. Pradeep Moonot to introduce themselves, their title, and go ahead with the presentation. So it's all over to you, Professor Dr. Siddharth Sharma, for your
Thank,
case.
thank you so much, sir. So, good afternoon, everybody. And thank you, Parekh Family Foundation and Dr. Rajiv Shah, sir. My name is Siddharth Sharma. I work as additional professor at orthopedics at PGI MER Chandigarh. And let me try and just share my screen. And, sir, please let me know if my screen is visible. I think
Absolutely.
it is. Yes. All right.
Yes, it is visible.
Okay. All right. So, to kickstart this session, I will be presenting.
We have lost your screen.
Oh, did I? Oh, okay. Let me just try again. I went to slideshow and I think then I ran into some problems. Is it better? Not yet. Is it visible now?
Not really.
Okay, I think I'll try stopping screen share and then starting again.
Yes.
Yes, it stopped. Okay, all right. Yeah, I think the problem is as soon as I go full screen, There's some problem that happens. So let me just run my slides without going full screen because we'll end up losing time that way.
Exit.
Yep.
Only through the window that we see here.
I'll run it through
Mm.
the window, sir. Yes.
Yeah, that's perfectly okay.
Okay. So I'll be presenting a case of post-traumatic talar deformity today. So this is a 16-year-old who came to us with a 4-month-old injury. So she said that she fell from a tree, twisted her ankle, and then had some swelling and deformity around the ankle. Didn't really see an orthopedic surgeon, was managed by a traditional bone setter, and then she was given some local ointments and all to apply. And she comes in with a painful, deformed foot, as you can see on the right side. So the heel is in a severe amount of varus, and she walks with an antalgic gait. So this is how she presented to us. So we took some radiographs, and at the first look, we couldn't really see what was going on. So this image on our left-hand side, it shows that the subtalar joint is not really congruent. There is something going on at the talar neck. Maybe there was a fracture which had united or not united. Maybe we were not very sure at this point of time. The AP view showed some sclerosis here in the talar body and a lucency at the top. Other than that, it was unremarkable. But then this oblique view, so this was an attempted canale view, but this sort of oblique projection showed us that there was indeed a fracture that had been missed or maybe mismanaged, and this was the case now. So I'll pause here and ask Dr. Rajiv Shah, sir, should we have some discussion at this point of time?
Yeah, yeah, whatever way you want to take your case, 14 minutes is what we need to finish this case, including discussion.
So,
Sure,
sir,
go
I'll
ahead.
I'll I'll go through the case, then we can have some discussion then. So at this point of time, looking at the X-rays, we weren't really sure, other than a non-united talar neck fracture which was going on. But to have some more information, we decided to go ahead with a CT scan.
Is this presentation on to presentation mode? Slide share?
No, sir, it's not. It's not in presentation mode because the screen disappears if you go to presentation mode.
If you could try once more, screen share. We see very small image. Oh,
Do you see the screen now, sir?
No,
yeah. Screen is lost, right?
it's lost here.
So, sir, that is the problem. So as soon
Okay.
as I go full
Go ahead.
screen,
Yeah, yeah. Okay.
as soon as I go full screen, I just lose the thing.
Okay.
So, sir, I'll try to magnify this and make it a little better.
Oh, great.
Right. So this is an axial section of the talus, and it shows that there is a non-united talar neck fracture. Is what you can see in this image. And then this is a sagittal section. We again appreciate the talar neck non-union, and you would also appreciate that the subtalar joint is subluxed.
Subluxate.
Yes. So here we have tried to do a 3D comparison. So we created 3D models of the talus of the affected side and the normal side. So red is the non-union side, white is the normal side, and you will appreciate that there is a little bit of a varus. From the front, we appreciate that there is a torsional deformity, and from the side, we see that there is a severe amount of dorsiflexion happening at this talar neck non-union. So this deformity, which is essentially a talar neck non-union, is a deformity in 3 planes. The major component that we could identify was a dorsiflexion deformity, which results in an anterior ankle impingement when the patient tries to dorsiflex. Then she also had a varus deformity and also a torsional deformity. So the point that I'm trying to make here is that these malunions or even non-unions are 3-dimensional deformities and must be appreciated in three dimensions. So, because she was a neglected presentation, we also got an MRI which showed a partial to almost full AVN. So, only a little bit of the medial side was spared, but all of the other body was showing avascular change. So, however, in view of her young age and the fact that she had not been managed appropriately, we decided to salvage the ankle joint in spite of the fact that this was an AVN. And as per the Ramelt classification, we would classify this as a type 3 post traumatic talar deformity, which is a non union with a partial avascular necrosis. So, how did we manage this case? We chose dual approaches. So the first was to go in from the lateral side. We chose a modification of the sinus tarsi approach. The calcaneofibular ligament that you can see here, it was sectioned and tagged with a suture anchor. And as soon as we did that, we could get a very, very good view of the subtalar joint, as you can see in the image here. From this window, we could reduce the subtalar joint anatomically and hold it in place with a K wire. So here the joint has been reduced, a laminar spreader was used. This helps in reduction. And because this was a dorsiflexion deformity, so the body of the talus has to be pushed in a cephalad direction and the head of the talus should be pushed in a caudal direction. So this is a video from a different case which shows us the reduction strategy, the exact thing that I was talking about. So here a periosteal elevator is being used and we are trying to push the body of the talus in an upward direction, whereas the neck can be pulled with a K-wire in a downwards direction. So next up, we did a medial approach, identified the fracture scar, opened it up, saw the talus from both the sides, medial and lateral, and fixed it anatomically with 2 screws. So the screw on the medial side, as you will see, is a positional screw. And because she was a young kid, 14 years of age, we did not fuse the subtalar joint. We used a K-wire to hold this in place. So at 4 months, union was achieved. The avascular necrosis did not progress. On the axial view and even on the lateral view, you will appreciate the suture anchor, which was used to put back the CFL that had been cut as a part of the lateral approach. At postoperative 13 months, everything had settled down. The avascular necrosis was what it was, but the ankle joint was salvaged. The AVN had not progressed, and the varus deformity was corrected, and she could walk with a painless gait, as you can see here in this video. So this is the end of the presentation, sir. I will stop screen sharing at this point.
So I think let's have an open forum where we can set the dialogue of question and answer. And my first question to Dr. Siddharth, I know you've done a great work onto talus and you've done a PhD also onto talar fractures. Intraoperatively, how do you, or what are your tips and tricks to analyze that your rotation of the head is proper? More so when you have a case like non-union, you don't have the ragged edges to tell you that, yeah, this is the rotation.
Sir, it is almost impossible to verify the rotation. But what we like to do, so if it is a malunion and we are doing an osteotomy, so we would put a K wire perpendicular to the or parallel to the body of the talus, and then another K wire parallel to the talar head. And then from my preoperative planning, I will know that when I get the appropriate amount of torsion, those two will become parallel. The best way to address the or assess the rotation is by doing a CT. So if some of us have a 3D fluoro based CT scan, we can do a reconstruction and we can measure it off. So there is a way to extrapolate the talar head onto the talar body and we can measure the rotation. But if we don't, then the parallel K-wire technique actually works very well.
That's right. And then did you not found any gap on the medial side where you had when you had thought of putting did you thought of putting a a wedge graft on the medial side? But that's very common.
Sir, because in this case, as you would appreciate from the preoperative planning, there was not too much of varus, but there was a lot of dorsiflexion and torsion. So as soon as we corrected that, we were left with a very, very small amount of gap on the medial side. She was a young girl, thick periosteum. We just put a positional screw in that position and it healed very well. But it's a fair point in a talar neck malunion, there is a varus, and oftentimes, more often than not, there is a need for a graft on the medial side.
And how do you decide for a forget about the delayed present, but in a fresh presentation, how do you decide pre-hand, pre-operatively, that this case you would require a medial malleolar osteotomy, this case you would not require medial malleolar osteotomy, and this case you would need a posterior-medial approach?
That is where the CT comes into the picture, sir. So we should study all the sections very, very carefully. And if the fracture line is going into the talar body, I would anticipate the need for a medial malleolar osteotomy. Of course, I would try to visualize intraop, but if it is a talar body fracture, the fracture line is exiting at or posterior to the lateral process of talus, I would need a medial malleolar osteotomy. And if there is an associated posterior medial or a posterior process fracture with the sufficiently large sized fragment, that is when I would also anticipate a posterior medial approach.
Okay, I have some different way of thinking at it. So when I see the absolute dead lateral view, I draw a line from the center of the medial malleolus, and then a line just parallel to the anterior part of the medial malleus. All the fractures which are anterior to this anterior medial malleus would go without osteotomy. The fractures who are between anterior posterior caliculi of the medial malleus, medial side of the tibia would go for osteotomy, but the fractures which are posterior to the posterior line of the so medial, if you trace the medial malleus posteriorly, the line going from medial malleus to the talus, if the fracture line is behind that, then I think that my osteotomy may not work. Girish has a point. Girish.
Uh, yeah, Dr.
Once
Siddharth.
Dr. Siddharth gives his opinion, then you please go ahead. Yeah, Dr. Siddharth, your view onto this?
Sir, this is a very, very interesting viewpoint. It's certainly something I've heard for the first time, and thank you for letting me know. I think it's a very, very nice observation.
Thank you. Girish, please.
Yeah, Dr. Siddharth, when you are planning to operate such kind of old neglected talar fracture, so do you need a CT scan, I mean the subtracted images to know about your rotations, and a MRI also to know about whether the AVN is settled or not, or only the CT is enough?
CT subtraction, absolutely, because the talus and the forefoot gets in the way and it becomes difficult. And subtraction is not really difficult. It's a small job for the CT technician. The MRI, I could argue both ways, because whether there is AVN or not AVN, we are still trying to salvage the ankle joint. Well, in this case, the patient already had it. So she had seen another colleague in the city and they had advised an MRI. But yes, we could argue, if anyways we are going to salvage the ankle joint, why get it? But on the other hand, you could also counter argue that if we were to follow up and see whether the AVN is resolving, so having something at baseline to characterize would also be useful.
Second quick question. In intraoperative situation, when you are want to sure that your varus is corrected, do you see the foot AP view or the hind foot alignment view?
Both, actually. So the AP view as well as the hindfoot alignment view should be good. So because varus is something which is happening at the hindfoot, also at the midfoot, forefoot. So I would try and get all of those aligned here.
Dr. Pradeep, please.
Yeah, hi. Fantastic case, Siddharth, as usual. Quick question. I know you got a CT. You have to have the CT of the other side and then you flip it to overlap it?
Absolutely, sir. So we get the CT of both the sides and then flip the the normal side that becomes a template for the opposite side.
And then do you use any special software to overlap? Because I don't think so. That's a normal thing which you would do in a normal PDF or JPEG or anything.
So there are specialized softwares for this, sir.
Okay. And one more quick
So,
question before we finish, just last one. You already had an avian of or partial avian at least. Did you think about doing a subtalar fusion for this? Because that would have got blood supply into the to the tailors and probably okay, we got a better outcome now. But if it was a collapse, then in hindsight, you would have thought about doing a subtalar fusion would have a better option.
Absolutely, sir. So if it was an older person, we would have definitely fused the subtalar joint, because anyways, when you're trying to reduce it, you are fiddling with it, the cartilage is damaged, and it makes a lot of sense to fuse the subtalar joint, also brings in the vascularity.
Sure.
so thank you. A great case. I wanted to ask you the last question. In a malunited talar fracture, when you're attempting a subtalar fusion for a subtalar arthritis, how do you decide, or what are your criteria to add or omit talar osteotomy? Because many times you just do the fusion, still patient is into virus.
Yes, sir. So that requires a very nice preoperative planning, sir. Varus can happen at the level of the talus, meaning thereby there is a varus. So I would do a 3D reconstruction, flip, and then, like the way I showed you, just see if there is any varus. If there is, then it needs a talus neck osteotomy. If the subtalar joint is dislocated, there is avian, I would also add a subtalar fusion. And in many of our cases, we have done both a talar neck osteotomy with a subtalar fusion.
So that was my idea of asking question. What are your indications for doing both?
Right, sir. Thank you.
Thank you, Dr. Siddharth. It was a great presentation, a great learning. And now it's over to you, Girish. You may please introduce yourself and then start sharing your screen.
Can you see it? Can you see my screen, sir?
Absolutely. Perfect.
Okay. Thank you so much. Thank you, Rajiv sir, Parekh Family Foundation. I am Dr. Girish Motwani, practicing in the center of the India. I have my own hospital. I am a director and the consultant foot and ankle surgeon at the Suyog Hospital, Nagpur. And this is just a memory of Endo-Parekh course, which we have attended. Fantastic course in January. Uh, this festival is very common in India, and a lot of youngsters they participate in Dahi Handi function, and I'm sure that it is happening in almost all the states of the India. So, a 26-year-old fast runner is a elite athlete. So somehow he endured due to this Dahi Handi
You,
program.
you could
Girish, we
move your
can't see your
slides. Your
screen.
slides are not moving.
Is not moving.
No.
Yes.
Okay, so same I think happened
Yeah.
like. Can you
Okay.
see now?
Yes, yes, yes.
Okay. Okay. So this festival is very common in India, Dahi Handi festival, and 26-year-old young athlete he fell down during this festival, and he injured his leg. So this was uh, uh, the injury, and this was the simple treated as a fibula fracture, and as a uh, as a deltoid avulsion injury in some other hospital. And you can see that the fibula has been treated by the general orthopedic surgeon just with the nail. And intraoperatively, they might have done some stress test, and they have understood that the injury is at the deltoid also, and somehow they have put a suture anchor just to tighten it. And this is how they closed everything. And 2 months down the line, this patient has started walking with the pain, lot of swelling. And then one X-ray was done uh, in the hospital, in the same hospital, and they found that there is something wrong in the position of the talus. And then they realized that something went wrong, and uh, there were too many instabilities at that time. So here you can see that these are the stress X-ray, which are showing that there is a significant amount of the talar shift is there. Tilt also you can appreciate to some extent that there is some opening of the medial more than a superior tibialis space. And this is the time when they found that uh, there is a lot of instabilities, and they referred this patient to me. And there is a clear cut shift, tilt, rotational instability of a fibula, although the length was maintained. The MRI and CT both were done. I'm not able to do the main screen, so that's why I'm sharing the same screen here. Uh, so posterior malleus fracture was there, which is conserved, saying that it is a very small, and this is the situation where, although they have fixed the deltoid, but this is actually the avulsion from the talar end, which is clearly visible as a avulsion fracture. And although the fibula looking like in sitting into the groove, but it is, you can see there is a widening of the tibiofibular space. I don't have an MRI image here, but putting a MRI report which is saying that the deltoid, even it looks a lax, there is a high grade injury to the AITFL and the interosseous ligament, which shows that there is a clear cut instability. So in this moment, I would like to ask from the esteemed panelist, Dr. Rajiv Shah sir, what should be, because he's an elite athlete, depending on its ankle for its sports activities. So how should we proceed in this stage?
So can you go one slide forward where you have a axial CT scan?
Okay.
So for yeah, and I think that MRI report, yeah, yeah. So for such a case, I would always get weight bearing as well as non-weight bearing views, because many times weight bearing views would cheat you correcting the deformity on weight bearing. So that's one. Second thing, I would always get comparative axial CT scan of both the limbs. That's very, very vital for me to plan where are we heading for. And the most important thing, this patient, we must try to salvage ankle.
Siddharth sir, here, although the CT is showing that the fibula is sitting into the groove, but the posterior malleus is not fixed. Do you feel that intervening at this stage, 2 months down the line, can give you a better position of a syndesmosis?
Siddharth,
Girish, I would need to see more than one section because rotational malreduction is very, very hard to pick. And in one section, and like Rajiv Shah sir very accurately pointed out, unless you have a CT of the other side, I don't really know what the normal for this ankle looks like.
Pradeep
And
sir, how do you?
even though it is delayed, I would agree with Rajiv Shah sir that this is a young person, sports person. We should try to salvage it as much as possible.
Pradeep
yeah,
sir, your quick
yeah.
comment. Do you accept that medial instability?
No, not for this patient. Definitely not. I would
And for the
intervene
other
against
patient,
this.
non-athlete patient, or the 40-year-old patient, do you accept this weight-bearing X-ray 2 months down the line?
No, I would not accept it. That medial clear space is definitely opened up. I would not even accept even in a 50, 60-year old because you definitely, this patient in few years will have arthritis.
Just tell me your quick plan to when you are revising this patient.
Okay, assuming the fact that the fibula length is normal, assuming the fact that the fibula is rotation is normal, okay, so that is one thing I would length rotation, compare it with the CT scan of the other side. If that is good, then I would first do an ankle arthroscopy, assess it. Medial side, definitely I would need to tighten up. The deltoid, I think he was averse from the talus, but he put an anchor on the deltoid on the medial malleolus side. So that is loose as well. Also, we have an MRI scan?
We don't have scan, but it's showing the complete rupture of the AITFL, intraosseous, and the deltoid is also loose.
Deltoid is loose as well. So, and the fragment size at the posterior size?
It is united, sir. It is. Can you see in the CT? It is united. It's very small, sort of PITFL avulsion fracture.
Okay. So, I would probably not go and try to do the PITFL or get the posterior malus reduced, but definitely needs a stabilization of the syndesmosis, the key thing is to use either two screws or two types of flexible fixation or a hybrid, but having AITFL, interosseous, and PITFL stabilized, all three. So,
Okay.
divergent type of fixation for the syndesmosis.
Thank you. So this is how we have decided to save the because it's a light athlete. So anyway, you want to stabilize the fibula into the groove, which is we are not sure that it is the intervention can help us better. But considering the CT and the MRI, the images, whatever the available as a non-weight bearing images we have, definitely it's a rotationally unstable fibula. Although the length is maintained because it's not a comminuted fibula, but still to correct the rotation, the plate was put inside. The plate was put and the nail was removed. And before doing the plate, uh, we clear the medial clear space. We open the medial clear space using the another incision, because the previous surgeon used a direct medial approach because that's a convenient for them. So, because it's 2 months down the line, we clear everything because the middle clear space was widened from day one, and it has created a lot of tissue. So, before putting a plate, that was done, and the fracture was mobilized, and this is how the stabilization was done. And you can see this is the intraoperative image showing a syndesmotic closure with the tightrope, revision of the deltoid. The video, I am sure it will not work. I have everything, but it will not work. So I'm just going to the last post-operative images. And here you can see that the medial clear space is also closed. There is no talar shift. There's no talar tilt. And it's 1 year down the line in the post-operative X-ray, you can see that the weight bearing X-ray, everything looks good and there is no instability. So the key thing here is the fibula is rotationally unstable. The deltoid was just done in presence of a syndesmotic injury, which is an inadequate correction to the deltoid, and of course the syndesmosis was mixed. So everything got corrected, and this is the function of a patient 1 year down the line. He is trying to do everything now with a very minimal pain on severe exercises. Otherwise, he is doing everything. We did a recent MRI also to see the integrity of the ligament, and which is showing no instability, and the patient is doing well. Thank you.
Great case, Girish. We will set it open for the discussion. Over to Dr. Pradeep. You want to ask something?
Girish, excellent case and excellent presentation. Syndesmosis, did you put two screws and did you diverge it or did you put it straight?
So, in the CT scan, it was very sure that I'm in the groove. So in all the images, the fibula was inside the groove. So in the posterolateral approach of the fibula, uh, we we did an open reduction of the fibula, and a tight rope was inserted. So what I do is I put a two wires. I don't open the syndesmosis in this situation because it was inside the groove. So I put a two K wires. So one was the blocking wire, which was preventing the anterior subluxation of the fibula, and one was provisional wire through the fibula into the tibia. And then in this situation, we put a tight rope. Of course, little 15-degree anterior position.
So only one tightrope.
Only one tightrope. And
Okay.
we did a revision of the deltoid as well. So you can see the previous anchor is removed and the deltoid is the new anchor was inserted to close the deltoid in the tight position.
So let me ask to every panelist that who would put in tightrope, one tightrope in a neglected case, or who
It's just
would?
2 months. Two
Uh,
months.
yeah. So I would not put tightrope. I would use screws.
Yeah.
Siddharth, your viewpoint,
Cruise, sir.
and Rahul. Welcome, Rahul.
Yes, hello everyone. So I might use tightrope
No,
again.
you, you're not audible. Raise your volume, Rahul. You're not audible.
Okay, am I audible now? because I have also unmuted myself.
We can hear you, but yes, it's the voice is not clear.
Voice is not clear. Dr.
Okay.
Pradeep, would you use screw or tightrope?
So I would definitely use one tightrope, one screw, one tightrope, or as I said,
Two
two
tightrope.
ropes diverging, one for AITFL, one for PITFL. But I would not rely on one, even at 6, 8 weeks afterward.
Yes, six, six, yeah. Uh, Girish, Rahul, Rahul,
Yes,
next
sir.
So
presentation will also be yours. So we need your voice.
So just give me a second, sir. I'll try to sort this out.
Yes, this is
So it was
okay.
just a 2 months old injury, and in all neglected cases, my choice of fixation for the syndesmos is always screw. In this situation, because it was just 2 months down the line, and everything, I mean, the posterior malus was not into the position. There was not on table too much instability, so I just was okay with the one tightrope. Otherwise, two tightrope for the athletes. Yes.
Sure. Yeah.
So is it
So,
better now, the voice?
yeah, last question. Pradeep Pai. Dr. Pradeep?
Yeah. So on the deltoid side, we saw that there was an avulsion from the talus. Would you still
Yeah.
go ahead and tighten on the
So
deltoid on the medial
So by
malleus?
the time, yeah, so by the time if I'm doing a surgery on day one, suppose this patient has directly come to you, I would have fixed the deltoid to the talus. But if this is a soft tissue which is already healed, and what we repair is a superficial deltoid. So by the time in 2 months everything was a fibrotic. So I did a revision at the previous level only.
Okay.
Great case. We still have discussion onto the similar kind of case. But over to you, Dr. Rahul. Please introduce yourself and start with Girish. You would have to stop presenting
Yes,
your screen.
sure.
Over to you, Rahul.
Right, sir. I'll just share my screen. Hello, everyone. I
Yeah,
hope my screen is visible now.
absolutely. Go ahead.
Right. Thank you, sir. So, to start with, I would like to thank Parekh Family Foundation for this opportunity, Rajiv Shah, sir, to count me in for this. I am Dr. Rahul Upadhyay. I am foot and ankle surgeon in Jaipur, Rajasthan, which is northwestern India. And I also work in New Delhi, which is the center and the capital of India. So, this is a small case presentation on a malunited neglected calcaneus. So this lady, let's call her Miss X, was a 32 years old female who had a fall from height, and she sustained injury to her bilateral calcaneus nearly a year back. So basically, she attempted suicide, so she jumped from height. She also had a lower spine fracture, which was operated, but the calcaneus was managed conservatively with a plaster cast. And when she came to us nearly a year later, she had bilateral severe hindfoot deformity. She had pain while attempting to walk, and honestly, she had not actually started walking for years, for 1 year now. She barely walks a couple of steps till the washrooms and gets back. And severe deformity causes difficulty in the shoe bearing. So this is how the foot looks like on table. If you see the heel, it's uh, even outside it looks nearly 25-30 degree in severe varus. So it was a broadened varus heel, severe subfibular impingement, restricted subtalar movements, and very tight gastroc. If we look at her X-rays, so this was the condition of her X-rays, and the angles on both the sides we have shown it here, which is 9 and 10 degree respectively. Uh, Angle of Gison was increased, the calcaneus pitch was barely there, and severe heel varus. So this is how the heel looked like, and which was the most troublesome aspect of this injury to her, that was making it very difficult for her to walk. So at this point, the question that came to our mind is our only aim is to make her walk, to make her stand, because with such a severe degree of deformity at the heel, she was literally unable to even stand. So walking was out of context for her. So the various ideas that we had was, okay, we have to correct this deformity, which is quite severe, nearly 48-50 degree of deformity on each side. So again, as we discussed, we did all the pre-operative evaluation. CT scan was also done for this. Again, uh, was CT really helpful in the deformity correction for this case? It could have been if we had done a 3D reconstruction and then a 3D model and then tried to correct the deformity on that first. So that's the reason, because I did not do it, so I'm not sharing the CT. So next question was how to correct this deformity, what approach to use. Do we use a synaesthesia approach? But again, the deformity was too severe. There could be issues of wound closure because once I try to elevate this calcaneus height, I might not be able to correct it. Romosh type osteotomy was kind of not possible for this severe deformity. Posterior lateral, again, it was difficult to address the deformity in this case. Extensile was one approach that I thought could address most of the issues that I want to handle, which is one, the correction of the varus as acceptable as position as possible, because I was not hoping to get absolutely normal heel in this case. Decompression of the peroneal tendons, again, I thought I could do it with extensile. And I was sure that I would be able to close, because with the idea that I had to do the osteotomy and correct this varus, I thought that I would end up giving a shortened calcaneus in the length. So that would not make it difficult to correct the wound over the extensile approach. So we went ahead with the extensile approach, and this was the entire plan that we had done. A gastroc release, a subfibular exhaustectomy, a peroneal decompression, lateral closing by the osteotomy of the calcaneus, destruction arthrodesis, and bone grafting using the same wedge. So this is how we started. We marked the osteotomy site using 2 KYS over the cora. We took a large lateral closing wedge. So you see this is a huge wedge that we took out of this. And as I said, we were aware that we'll be doing a considerable amount of shortening of this calcaneus, but this was a part of the severe deformity, so we accepted it. So this was a huge wedge that we took out. And once we had done that, we did an osteotomy. We made a dissection to start with, did a temporary K-wire fixation. So this is how we did it. And once that K-wire was fixed, we put a screw. Now the idea was to have a very good compression on the lateral side. It was really difficult to get this correction, because all the force that we could apply was, again, it was very difficult to get it back into a neutral heel. So this lateral screw was all the way on the just under the lateral surface of the calcaneus that we put in. And once we had compressed that, we put in the same lateral wedge and used as a subtalar joint fusion using the bone grafting. And this is how it looked like. So now you can see this screw. If you see, it is all the way lateral, because any more medial and we were not able to control the deformity, it would fall back, it would not hold. We had kept a couple of K-wires in situ at that point of time, because there was not much space to put in more screws into it. There was hardly any calcaneus on the posterior aspect, so we had to go ahead only with the 2 screws and multiple K-wires. And this is how it looked like nearly 4 months. So we had to keep this even the last 4 months. Also, given the mental status of the patient, we had to wait. And so this was the final deformity correction that we were able to get in this patient, which was quite acceptable. Barely around 4 to 5 degrees of varus was at the end. So what were the goals that we were able to achieve? We were able to correct the varus, quite acceptable range, much better than what we thought. Yes, of course, the peroneus was able to decompress. The height was able to achieve. We achieved a good overall height, if you see here. And yes, there was a considerable amount of calcaneus shortening, which is visible on the post-op X-rays. But we had to accept this amount of shortening. And patient was able to walk. Obviously, it was a bilateral deformity amount of limb, but walking was, which was more advisable and admired by the patient. So we were able to achieve that goal at the end. So thank you. This was a short presentation over this malunited calcaneus.
Rahul, it was a great exposition of reconstruction of calcaneus in a very, very tough case. And I really congratulate you on your endeavor. Few comments. I feel that we should not be thinking about any issues for such a case, and we should be going ahead with lateral extensile approach only. Because, anyways, when you're doing a shortening on a lateral side, you're going to get the skin closer easily. Even if you lift the calcaneus, if you lift the height, if you increase the height of calcaneus, that always is an easier thing. Second thing, when I start with such a case, I had I think 4 5 such cases operated. I first start with a plantar fascia release, complete plantar fascia release, and I take a long approach because these cases many times do not come up with only gastrocnemius. You need to do a Z-shaped open tendoachilles release. So my incision goes quite posteriorly over tendoachilles and then it comes anteriorly. So I do open Z lengthening of tendoachilles. I do complete plantar fascia release because whatever you do, your wage which you remove is going to fall short in such a case. So once you do the plantar fascia release, once you do the gastrocnemius complete tendoachilles release, you do Dwyer's correction plus shift that Dwyer laterally. That will be the only way you would be able to put your screws right into the area where you want to put. So the problems of a screw were because you did wire, but you need to shift it laterally. And had you done that, there should not have been problem. What I do, I fix the wire or slide and wire both with the small K wires, then lift up the height, put in the wedge which I removed into that, put in 2 or 3 lost K wires from that wedge into talus, wedge into calcaneus, and then with an ease I put my subtle fusion screw. But great case. Any other comment,
Thank you,
question
sir.
on to this
Yeah, Rahul.
Rahul case?
Rahul, in such situation, many times, like when you feel that your screw from the tuberosity to the posterior talar body is not going to be in center. In many such situations, the screw from the anterior calcaneum to the talar is also a very good bone stock. Also, when you have a negative polar angle, your weight bearing shifts to the anterior facet from the posterior facet. So in most of the time, these facets are very much arthritic. So anyway, that screw will help you to fuse the anterior facet also, which is a good pain relief, and you can start early rehabilitation.
I have never done
Right.
a post calcaneus malunion subtalar fusion without fusing all other facets.
Fine.
Anterior subtalar joint,
Three
middle
out of three,
subtalar joint, and posterior subtalar.
always.
Yeah,
Always.
and when you put in your anterior screw, you tighten that screw first. That is going to bring your talus down. That is going to help you bring talus down. So that would be the first, simultaneously with the screw which you are putting posteriorly. And if all this maneuver fails, I always keep small plates with me. So you can put in a plate from talus to calcaneus, talus to calcaneus. Many revision cases badly done earlier, I have put in a plate which would fix and fuse the talus with the calcaneus. Uh, Pradeep, Dr. Pradeep, you had a question. Dr. Siddharth also had a question. Maybe you can take it one after another.
Sure. No, I think great case, Rahul. Only one thing, and I've learned it in the last lot of distraction arthrodesis. I think I always try to undercorrect the hindfoot height. Do not get them jack up so much. It is better to have a lesser tailor declination. People do not like it. People with mild flat foot, mild loss, they accept it. People with large hind foot, great correction with slight varus, they will never like it. They will be the one who will keep coming in your OPD and complaining. Somebody with a mild loss of height, mild flat foot, they never come. That's the only thing. Thank you.
Dr. Siddharth,
Is also very similar to what Dr. Pradeep was saying. And building upon that, so when you do a large varus correction, number one, we are shortening the calcaneus a lot. Rahul, you already talked about that. And my worry sometimes is that are we decreasing the lever arm of the tendo Achilles too much? Number one. Number two, there is also concern about a postoperative tarsal tunnel syndrome when you do large varus corrections. So, at what point of time, is a question to you and all the panelists, would you ever consider doing prophylactic release of the tarsal tunnel for
always,
these very, very large corrections?
always large correction where I'm not only doing the wire, but I'm also shifting it, and where my shift could be more than 5-6 millimeter. Absolutely,
So
Thank
do
you,
you
sir.
need a separate incision, medial incision to release the posterior tunnel?
absolutely, absolutely.
Absolutely.
I
One
think
important challenge in that this particular case, just to add to this, is this patient had actually not walked for 1 year. So the quality of bone was also such that I could, compress it with my hands and it would just burst. So there was no space for me to try and put screws again and again. I just had to be very focused on this. So how do you treat such situations? How do you, handle these situations when the bone quality is like osteoporosis is an underword for this. That was so bad.
I think we will have to just close this case. But my comment, many times I've added external fixator together with this correction, and you
And
can
Rahul,
remove the external fixator
the
after
fully threaded screws always help.
4 to 6 weeks. You can remove the external.
That's all.
Although I think we have another 7 minutes. Sorry, Pradeep bhai. Go ahead and start with your case and your introduction, please.
Okay, sorry. Thank you so much. So Chrome tab, is it in the Chrome tab it comes with sharing or all windows?
All windows should be the better.
Windows.
Okay, can't see all windows. My okay.
No, you will. It will be at the top.
No, okay. Wait, hold on.
Yeah.
Stop share, share again. Windows doesn't come anything. It just comes as this only.
No, but
So
you
whole
have your.
whole screen, share the whole screen, and then you can go to your presentation.
Entire screen. Okay.
Entire screen, and go to the presentation.
Okay, can you see that?
No. Yeah.
Yes.
Now go ahead, sir.
Okay, so I'm trying to see if you can get it. Can you see it?
Yeah, keep it in this mode only. Yeah, better.
Next, I moved the slide.
Yes, visible.
Yes.
Visible. Okay. So
Yes.
thank you very much, both Selene Parekh's Foundation, Rajiv Shah sir, for inviting me for this great 24-hour town hall talks. Have been great sessions till now. So I'll be talking on malunited ankle fracture. I'm Dr. Pradeep Moonot. I'm an executive member of the American Foot and Ankle Society, practicing in Mumbai and other places as well. Also the section editor of the Indian Journal of Orthopedics. Quick case, 29-year-old male sustained injury to the left ankle due to RTA. X-ray showed a bimalleolar ankle fractured, managed surgically with open reduction internal fixation, and then came to us 8 months after surgery. So this was the original fracture which he had come with. Closed injury, but lot of skin lacerations present both medially and laterally. Had this surgery done, open reduction internal fixation, medial malleolus KY done and screw, lateral plate done. I don't think so. It is a great fixation. 4 months later, he comes to me. Girish, what do you think about this?
Yeah, so there is a, you can see there is a clear cut shift, shortening of the fibula. In the lateral view also you can see the fibula is shifted more anteriorly. So definitely the syndesmosis is missed and maybe malreduced.
Maybe malreduced as well. Also, and also at 4 months, can you already see the joint space is also narrowing?
Getting good.
Okay, so what went wrong? We've gone through that. So open syndesmosis, clearly you can see that talus is already shifting, that the medial clear space is already opened up. Joint space is also reduced and ankle is already in valgus. So he came to us at 8 months' time. This is the picture he came with: ankle arthritis, syndesmosis, and ankle valgus. Um,
Uh,
Siddharth,
Sorry. So, for all of you, what is your bottom line? By how many months you would not reconstruct syndesmosis, or you would go for fusion? Any ballpark weeks, months for you, all of you, please?
so are we talking fusion of the syndesmosis or
Yeah,
reconstruction?
I'm talking of syndesmotic fusion versus syndesmotic reconstruction.
Ah, okay, okay, okay. So
Up
I
to
look at,
6 months. Up
sorry.
to 6 months, the syndesmosis can be reconstructed.
And Dr. Siddharth?
Up to 9 months, sir, although there is no hard evidence to support anything.
No, sir, there is an evidence by Panos who has written multiple articles onto this, and he says 9 months is his limit. Till that time, he tries to salvage syndesmosis, else he will go in and do the fusion. Please, Pradeep bhai. Oh, go ahead, please. Sorry.
Sorry. Also, I think if I'm not wrong, long time back I had spoken to Remart as well. I think if there are no changes, and Remart's paper also, if there are no changes of arthritis in the syndesmosis, I think he has shown reconstruction even at 2 3 years and they worked well. But again, I think maybe just one of our personal discussion. So this is what he came with. Look at the hindfoot valgus, hypertrophic medial scar present, um, and pain as well. So investigations wise, of course, weight bearing X-rays, MR, CT, or anything else you want to do it. These are the CT scans which we have it. Look at that arthritic joint present. AP again, coronal views, ankle in valgus, fibula is short, syndesmosis is open up. That's your axial view. Syndesmosis look to be reasonably in place. Of course, we would want to compare it on the other side. Siddharth, what would you like to do? Young patient with this injury coming to you 9 months after the injury.
I would have a good discussion with him about salvage versus fusion and try to salvage it, so try to get the ankle in a as good a position as it can and then see where it goes. I would try to salvage it.
So you would like to salvage it in spite of this kind of arthritic picture?
Yes, sir, in spite of that kind of a picture, because sometimes what is radiologically looking very bad may not be functionally very bad.
Sure. Okay. Okay. Anybody for fusion at this? Rahul, Girish, Rajiv sir?
No,
No, fusion.
Fusion, Rajiv? Sorry,
we
Girish.
have we will have to sum up this case quickly. We are
Okay,
running
okay. So we know
out.
the fact for Indian population, ankle danger movement is a must for day-to-day activities. These are the kind of movements which we require. Yes, we can do fusions or replacements, but they have their own downside, and especially younger patients. We know that joint replacement options they do well, but still they are not as good as normal or not normal. They're not never near normal anyway. So, as Siddharth already mentioned, we have joint preserving options present. And these are the different kinds of options. We're not going to go there. So, what we're talking today is like the why SMO in ankle OA. Younger, higher functional demand patients, they do quite well with supramalleolar osteotomy. It realigns the joint and, of course, allows or delays the fusion option, or if you realign it well you can future can do a total ankle replacement as well. The key questions to ponder when you're doing an SMO: does it really improve the clinical outcomes reliably? How effective is the radiographic correction? Does preoperative tailor shift OA stage affects the results and can delay or avoid? So we've gone through this. SMO, young patients, more than 50% cartilage should be preserved. Failure of conservative treatment, and of course, you have to have a malalignment, but not too much. If you have asymmetric joint space narrowing, that means there is a tailor till present. You may not get adequate correction through SMO alone. You may need to think about something else as well. Contraindications, we have gone through things. Again, I will not go through that. Let's look at the case which I presented. So, reanalyze. So, this patient had already visited two other surgeons from other places, and they had suggested fusion. He was very clear he did not want fusion. So, he had this in the mindset, whatever it is, I want to have a salvage. So, we had this discussion, long thing. Pure planning in SMOs is very, very important. You want to get all your angles right in AP view and in the lateral view. So looking at this, your talocrural angle and your TAS angle, both you should be knowing it. Okay, so here these are the angles which were done. Our plan was to preserve the joint by realignment procedure, implant removal, supramalleolar wedge osteotomy, and then a syndesmotic fusion. So the step one, all the implants, medial side, lateral side was opened up. A supramalleolar osteotomy was planned, okay, like this. So what I do is the one wire, I keep it parallel to the joint surface, the other wire parallel to or perpendicular to the shaft. What is the angle you get? That is what the wedge you take it out. So that was the wedge taken out. Keep the hinge intact. I've just taken on the fibula side, you just remove the implant, break it where it was initially. As soon as you correct it, the fibula also gets automatically corrected. And here you can see the tailor or the joint line is now horizontal. This is where I want to be. Hold it with a K wire and then put in a distal tibia plate. You may need to mold it to the surface and fix it. Once that's done, the fibula is lengthened up, fixed it, and use that bone graft on the lateral side, which you got from the medial side, put it on the lateral, and here we did a syndesmotic fusion as well. And this is the post-op X-ray. These are the serial X-rays which I've done, and here you can see how the joint surface actually over a period of time, and I think if we see the Japanese data over a period of time, the joint keeps looking better and better. And these are the images over a long-term period. The syndesmotic is fused. He's much better. Alignment is looking really good. He's very happy. This was the pre-op X-rays and the post-op alignment. And there you can see this is more than 2 years follow-up patient, doing quite well. No pain at all. He has, I wouldn't say no pain. He has some pain, but he's very, very happy with the outcome as well. Um,
Thank you very much, Pradeep Bhai. A great case and a great discussion. We'll have to stop here
sure.
because organizers want us to stop. We are already 4 or 5 minutes, you know,
Yeah.
overscale. Thank you, all panelists. It was all a great discussion and great cases. Thank you very much.
Sir, can we take a screenshot, sir? Everybody, if it is Rahul, can you put on the your photo? Then we can take a screenshot.
Uh, Rahul is not here. Anyway, I've taken a screenshot. I'll share it with you. Girish
Okay.
also.
Thank you. Thank you so much.
Thank you,
Thank
sir.
you.
Thank you, Rajiv sir.
Yeah. Over to you,